All right, so as you know, today's session is about randomized controlled trials. I will be referring to this as RCTs. So we'll specifically be discussing foundational aspects of the RCT, how and when to use RCTs, including a specific focus on the main features, types of biases, reporting, and critical appraisal. And finally, putting everything together to analyze its strengths and limitations. So I'm sure most of you have heard of a randomized controlled trial and maybe have read one. What an RCT is a clinical investigation that involves intentional change in some aspect of the status of the participants. So you would have one or more groups receive a type of intervention and then compare that against a control group that does not receive the intervention. And because RCTs can exert a level of control that minimizes bias, and we'll talk about this shortly, these are considered the gold standard for testing cause and effect through primary research. As you see in this hierarchical figure over here, you have randomized controlled trials being on the top of the ladder of what they call unfiltered information, so more on the primary research side. After which you would have your systematic reviews and meta-analyses that would quantitatively synthesize and consolidate evidence from RCTs or other study designs as well. So let's visualize this. You have your sample population, and in a typical design, you start by targeting a population sample into your study. So your participants are randomized and allocated into your control and intervention group. And from there, participants in either group could show a positive or a negative response in terms of the outcome. In other words, participants who are allocated to the intervention group could develop or not an outcome, and the same goes for the control. And what we can then see whether the change in our outcome was different in the group that received the intervention than the control that did not receive the intervention. So this type of design is the most common, being a parallel design. And this is where the participants, as you saw, are recruited individually before group allocation. The second common design is the cluster randomized controlled trial. And here, the group, as opposed to the individual, is actually the unit of allocation. So this could refer to hospitals, to schools, community centers, religious facilities, and it's these groups or the site that is randomly assigned to receive control or intervention. The third common design is a crossover randomized controlled trial, where you can think of it as a repeated measures design, where each participant acts as their own control through a sequence of treatments, where they receive one treatment, then there's a washout period, and then they receive the second treatment. And because these participants serve as their own control, the advantage of this design is that it requires fewer participants to enroll to achieve the same power in the study. There are other designs as well, which we won't go into today. NF1 design, factorial design, adaptive design. There's a recently emerging patient preference trial is what they are referring to it. So there's more advances as time goes on in this area. Now, across these designs that we saw, you could plan for an RCT to be explanatory or pragmatic in nature. So focus your attention here on the shaded space in these two figures and how much they occupy. You then see that in a pragmatic trial, there is less rigidity on the trial elements. So with a pragmatic trial, you're specifically looking to maximize the results of your trial to general practice. For example, for a pragmatic trial, you would tailor characteristic features of the trial to perhaps select a clinically relevant alternative intervention to compare. Or you would include a diverse sample population of study participants. You could recruit participants from heterogeneous practice settings. You could collect data on a broad range of health outcomes that are more perhaps patient-centered as opposed to disease-centered, like in the explanatory model. So another way to see this is that a pragmatic trial offers benefits for external validity, whereas an explanatory trial aims to establish cause and effect by offering benefits to internal validity. Now, with this in mind, a single trial can incorporate some elements that are more pragmatic and other elements that are more explanatory in nature, and it all depends on the trial that you're wishing to complete. Now, across any design or type of RCT, you require a good clinical question, and this research question should have 5 or sometimes 4 essential components. These refer to the patient or problem in question. I refers to the intervention. Then you have your comparator, your outcome, and your time frame. An example of this could be compared to an advice-only group. How effective is fluoride treatment given once every 6 months to children 2 to 3 years of age in preventing caries after 3 years? And you can see here the distribution of the PCOT elements based on this question, where you have your population of children 2 to 3 years of age, your intervention, your comparator group, the outcome that you're interested in, and the time frame that you're interested in measuring this outcome. From your research question, you can then identify your independent variables, your dependent variables, where your independent variable is your intervention, and this can be on a continuous or a categorical scale. On the other hand, your dependent variable is your outcome. So your outcome could be looking at a variety of measures relevant to your study, from behavior change to measurable health outcomes. What's important to keep in mind here is that the confounding variables that may affect your dependent variable. So ideally, the randomized design would protect from differences between groups and confounders, but we will get to that shortly on ways that you could confirm. Okay, so what really is so attractive about the RCT design? The first thing is that your participants are randomized. And so this means that participants have an equal chance of being allocated to the intervention or to the control group. There are several types of randomization. The most common one is called simple randomization, and this is like flipping a coin. There's a 50% chance of someone ending up in one or the other group. This can sometimes lead to unbalanced groups, so block randomization is typically recommended, and this is designed to randomize participants into groups that result in equal sample sizes. And this is especially the better option for trials with smaller sample sizes. Another type of randomization is stratified randomization, and this is where participants are matched on the basis of covariates that are of interest to your study, like weight status or gender. So you can ensure equal allocation based on predefined characteristics. Now, the second and third key features are the allocation concealment and blinding, or more recently referred to as masking. Sometimes people confuse the two. The difference is that allocation concealment refers to keeping the assignment sequence unknown before and until the point of assignment, so until the point that you actually reveal the assigned group. Whereas masking refers to keeping the assignment unknown after randomization and for the duration of the study. And this can't always be implemented depending on the type of the trial, but it's always best to try to ensure that masking is achieved. Now, these same key features that I mentioned are what can protect from bias in an RCT design. So when you randomize your participants, what you're doing is you're actually protecting from selection bias, and you're ensuring that the group characteristics are balanced. And in an ideal world, they would be, but of course, you should always confirm at the results stage. Allocation concealment can also minimize selection bias. And accepted ways for randomizing include a computer-generated algorithm. And for allocation concealment, then you would take that algorithm and you would include the allocation in a serially numbered, sealed, opaque envelope, as an example. The second type of bias is performance bias, and this refers to differences that occur due to the knowledge of the intervention allocation, either by the researcher or by the participant. And the reason this is problematic is because it can result in differences in the care that is received by the intervention and control group if a personnel on the trial is aware of the allocation. But this type of bias can be minimized by masking, which is the technique we referred to on the previous slide. So of note here is that performance bias is introduced by unequal care between the groups, and it has nothing to do with how the outcome is assessed. This is where detection bias comes in. And this is what we refer to as the systematic difference between groups of a study and how the outcome is assessed. And this can also be minimized by masking the outcome assessor in this case, so whoever is assessing the outcome and conducting the measurements in the study. The last two types of biases are attrition and reporting bias. So attrition bias refers to withdrawals or participants who are lost to follow-up over the duration of your RCT. This is a tricky business because in RCTs, you'll find many analyze their data using what's called per protocol analysis or complete case analysis. So you might see these terms used in published RCTs. Now, conducting the analysis in these ways, which is only using participants who completed the intervention, participants for whom you've had measures, can lead to bias unless the data are missing at random. And this violates the principle of intent to treat analysis, or ITT. This is the recommended analysis for RCTs. An easy way to remember what ITT refers to is the saying, once randomized, always analyzed. And this is no matter what, regardless of whether you had participant deviate from the study, whether you had withdrawals in participants. Essentially, the reason this is the preferred method is because it helps to preserve the benefits of randomization in the first place, which you cannot assume to hold true when you use other methods of analysis. So by doing an intent to treat and conducting the analysis on all participants who were randomized, even if you don't have all their measures taken at all the time points, there are statistical ways you can adjust for those, but essentially you are taking all of the participants who were randomized in the early stages. Now, reporting bias is when the author chooses what to report based on their preferences or any other reason, which happens more than you think it would. All of these biases that we spoke about can exaggerate treatment effect. And so I've put them here as a summary so you can see all of the different biases together, what these mean, and how we can aim to minimize these biases by conducting a rigorous randomized controlled trial that includes randomization, allocation concealment, masking of the personnel, masking of the outcome assessors, masking of participants if possible, conducting the right type of analyses using the ITT approach, and of course, non-selectively reporting your outcomes. In terms of reporting, there are reporting standards for RCTs. For an RCT, you're looking at what's called the CONSORT. I won't go into too much detail on these today, but this is a snapshot of the CONSORT, which is a checklist. And if you were to zoom in here, you would see that one component of this checklist is actually having a flow chart similar to what you see on the screen here. And you can tailor this depending on the study type. So if you were doing a crossover study, as you see here, there's been a switcheroo in the treatments where your participants received treatment A first, they had a washout period, and then they received treatment B, which is in line with what a crossover RCT is designed to do. All right, now putting all of it together, sometimes you want to critically appraise an RCT, either to include it in a systematic review, a newsletter, or just for fun, if that's up your alley. So there are ways you can do this. You can assess an RCT by its relevance, by its novelty, by how appropriate the study design is. Typically, critical appraisal refers to assessing the internal and external validity and methodological rigor of your RCT. So internal validity is referring to the biases inherent within a study design. External validity is referring to how applicable your experiment is. And if you remember earlier on in the presentation, we talked about the differences between pragmatic and explanatory trials, where pragmatic trials aim to maximize external validity and explanatory trials aim to maximize internal validity. There are checklists for these purposes. Some of these I've listed here: the CAS, the JBI, CEBM, Center of Evidence-Based Medicine. I will actually walk you through an example today using the JBI checklist. All of these are quite straightforward. Each of these has specific criteria that you would sort through to see whether an RCT meets those criteria. They are quite similar in nature, so it's up to you on which checklist you would like to use. So I've chosen this paper here. This paper was published in 2017 in the Journal of Dental Research. And it's an RCT on caries prevention in dental practice. So if you recall, the PCOT question that I had formulated earlier in the presentation was actually inspired by this paper, where they initially conducted a parallel grouped randomized control trial of children who were 2 to 3 years of age. They recruited children from across 22 dental practices. Now, if you read this, sometimes you might think it's a dental practice, it's a site, so maybe it's a cluster RCT where the unit of randomization is the group, but that is not the case here. They simply just recruited from multiple sites and they conducted a parallel trial where they randomized on an individual basis. So they had a particular intervention here related to fluoride treatments, and they had an advice-only control group where they had check-in points at 6-month intervals during the study, but their final outcome was actually selected a priori to be at 36 months, so at the 3-year time point. And their primary outcome was referring to the change from being caries free to, let me see how they phrase it here, to caries active children. So whether the number of children who were initially recruited as not having any caries changed across the intervention and control groups to be caries active after this intervention. So what I have here is the specific questions that were retrieved from the JBI checklist, and I've copied what they have reported in the paper that might be relevant to meet each of these checklist components, so we can see how this RCT fares when it comes to its critical appraisal. So the first question is, was true randomization used for assignment of participants to treatment groups? So as you recall, the differences between participants included in the compared groups can constitute a threat to the internal validity of a study where you're exploring causal relationships. So if a study is not allocating its participants based on random assignment, then there's a risk that the allocation is influenced by some characteristics of the participants, and then these differences between the groups can distort the comparability of the groups. Now, typically, yes, the randomized approach to the trial aims as much as possible to have balanced characteristics between the intervention and control group. Sometimes in an ideal world, that may not be the case. You may have, for example, differences in income still across the groups. And in these cases, there are statistical approaches you can take to adjust for these potential confounders if the randomization was not enough at that point. Okay, so here what you want to look for in the paper was whether a list of random numbers was used, whether it was computer-generated list of numbers. And you see here that they reported that the clinical trials unit that they had utilized centrally randomized children into intervention and control group using computer-generated randomization schedule. So that would be a yes. There was proper randomization. Now, the second question refers to the allocation to the treatment groups and whether that was concealed. So if those allocating participants to the compared groups are aware of which group is next in the allocation process, so if they're aware of the allocation sequence, then there may be preferential allocation of these participants to either group, and then this can distort the allocation process in general. So what you want to look for here is whether central randomization was used, which it was, and whether there were any sequentially numbered opaque sealed envelopes or other alternatives that could ensure that the sequence allocation was concealed. And here you see that they state the block lengths varied to ensure that the CDC examiners who completed the baseline examinations were blind to patient allocation. Now, sometimes this is a bit of a subjective interpretation of the report. I believe I did put this as yes, it was satisfactory. Just because they did a block randomization does not necessarily mean that the allocation was concealed. So this could also fit under unclear if that's what you choose to put in here. The third question is whether treatment groups were similar at baseline. So this again refers to the potential of being a threat to internal validity if there were differences, major differences between the groups. If there was one difference, then you can assume that your randomization was done adequately. If there were differences across the groups and all characteristics, then something smells fishy and there might be something wrong. So you want to check the characteristics reported for your participants and whether the compared groups are similar in regards to these characteristics. And typically, you're looking at sociodemographic factors or any other variables that were measured at baseline by the specific study. So here they actually state in the text that the baseline demographic data are presented in table 1, which is this table. And they say that there was excellent balance between the study groups for sex, age, quintile of deprivation, and practice, but that the data were not shown. Now, I chose to put this as unclear because typically you want to see specific values reported. And while they do say that there was excellent balance between the study groups, this is subjective, and excellent balance may mean something different for different people. So I would go with unclear in this case. Were participants blind or masked to the treatment assignment? So this is referring to if participants were aware of their allocation to the treatment group or the control group. And as I briefly mentioned earlier, the reason masking is important is because if participants are aware of which group they're in, then they may behave differently to the intervention. They may be more motivated to change their behavior, or depending on what question you're hoping to answer, they may simply partake in new activities, act differently based on the intervention that they are in. So masking the participants would then prevent these participants from knowing which group they are allocated to. And if they are not aware of which group they are in, then you would have proper masking here. Now, as I mentioned, sometimes this is not feasible depending on the trial that you are conducting. It's typically easy if you're looking at perhaps giving a drug capsule as the intervention, in which case you could give a placebo to the control group. But in other types of interventions, such as educational interventions, sometimes that's a little bit more difficult to achieve. So here, the authors actually did not refer to the blinding/masking of participants in their paper. It was not mentioned in the abstract, methods, results, discussion. So in this case, that would be an unclear. Now, we're still talking about masking, but now we're referring to those who were actually delivering the treatment. And same principle here. If you are aware of who is in which group, then it may lead to practicing differently. The personnel may behave differently with the participants from the treatment versus the control group and the care that they are providing. So then masking helps to minimize this risk. So here you want to check for details in relation to the different personnel who are involved at different stages in the trial and whether they were unaware of the assignments. So this is actually retrieved from the abstract. Sometimes the authors may include this information in the abstract and not repeat it in the actual body of the manuscript. So here they say that allocation was concealed from the dental practice until each child was recruited. So in this case, that would be a no, because this is referring to allocation concealment as opposed to masking. And if you recall, allocation concealment is referring to masking the sequence allocation up to the point of randomization, which is what this is referring to, compared to masking for the duration of the study, which was not done in this case. Now here, whether outcome assessors were blind to the treatment. So what you want to look for here is, were those who were assessing the treatment's effects on the outcomes of choice unaware of the assignment of participants to the compared group? And so here, this is the text that was retrieved from the paper. CTU for each practice using randomized permitted blocks. The block lengths varied. This is what we had seen earlier, but then they go on to say that the outcomes were assessed by 12 trained and calibrated CDC dentists who were blind to the allocation. So that would be our yes. Number 7, were treatment groups treated identically other than the intervention of interest? And so here they report that the control group did not receive any professionally provided fluoride interventions. Both groups received the same standardized dental health advice on optimal use of fluoride toothpaste and restriction of sugar consumption every 6 months at their dental checkup. So these groups were comparable in terms of the general advice that was received, but in terms of the intervention, there was no overlap in this case. And you would be able to go ahead and assume that the groups were identical aside from the intervention of interest. And keep in mind that this is actually a pretty decent paper where the authors explicitly report these outcomes. So they actually do a great job in terms of reporting everything they need to report. In a lot of trials, it's not as straightforward or as clear. And sometimes this is due to space allocations when it comes to publishing and how much you can actually fit for that specific journal's word count or page requirements. So just because something was not reported in the published manuscript doesn't mean that it didn't happen. And we've seen that in the previous questions where the blinding of participants was not mentioned. And so we rated that as unclear. Was follow-up complete? And if not, were differences between groups in terms of their follow-up adequately described and analyzed? So keep in mind that for this question, this is not about intent to treat analysis. This is referring to the loss to follow-up. So it's important to know more information about those who withdrew from the trial, not just in terms of the number of participants or the proportions of participants with incomplete data, but also the reasons for loss of follow-up, because even if the numbers and proportions of participants with incomplete data are similar or identical in the compared groups, the patterns or reasons for that withdrawal might be different based on the different groups. It could be due to side effects caused by the intervention. It could be due to other reasons that would be important to know that may impose a risk of bias if they're not appropriately described. So here you see that they did report the numbers of withdrawals in the trial across each of the groups. So they had 46 in the intervention group and 45 in the control group who withdrew from the trial. And then they go on to provide the reasons for the withdrawals. They do not specify the distribution across the different groups. So whether all of these 14 individuals.
Good morning. Today's work in progress will be presented by
We
Dr.
get
Peter Smoke,
some alerts.
11 a.m. Please join us in the Riley Auditorium and via Microsoft Teams. Masks are required. Thank you.
Okay, so we're all going to Riley Auditorium for another talk. All right, so back to number 8. So we can't know whether these 14 participants who moved to another practice were all from the intervention group or all from the control group, since it wasn't specified here. But what they do say is that many of their dentists withdrew children themselves because children were or families no-showed. And this was consistent with standard practice, which was not reciprocated by the research intent. And so they say that this was picked up at an early stage and these local policies were stopped for trial children. And so we're unlikely to have introduced any bias. Now, this question refers to intent to treat. Were participants analyzed in the groups to which they were randomized? So remember, once randomized, always analyzed. And so here they say that all statistical analyses were performed using STATA, using an intention to treat approach. And so you would think that because they say they did an ITT, that they actually did an ITT. But if you look further in the manuscript and you actually look at your flow chart here, I'm not sure if this is visible, but over here you have your randomized participants. 1,248 children were randomized to the test or the control groups. And then as we saw in the previous question, there were some withdrawals and there were some participants who were not examined for one or another reason. And so once you subtract those who withdrew from the trial or who were not examined for any of those reasons, then you actually have a total of 549 participants in the treatment group and 547 participants in the control group. And they say here that analyzed n equal 549, analyzed n equal 547. They say that they excluded 0 participants from the analysis, but this is considered a complete case analysis. This is not considered an ITT, because if it was an ITT, then you would actually have these numbers here that would have been analyzed. And as I mentioned, there are some analytical methods by which you can carry forward or take the participants who are randomized and analyze those as such, as opposed to only taking the participants who completed the intervention. So some discrepancies here, and this would then be no to ITT having been conducted. Now, in terms of the outcomes being measured the same way, this is referring to whether the same instrument, for example, or scale was used to measure the outcome, whether the outcomes were measured at the same time, whether the outcomes had similar procedures and instructions for measurement. And they did a pretty good job here. So again, they had the 12 trained and calibrated CDC dentists. And some of the outcomes were recorded by parental questionnaires, data collection from practices. No changes to the outcomes were made after the trial started. So it seems like the same measurements were employed for the different groups. In terms of reliability of the outcomes, this is where you want to check details about the reliability of the measurement. So you want to look at the number of raters, the training of the raters, the intra-rater reliability with the study. So essentially any measurement that showcases reliability across the outcomes that were measured in the study. And again, this is very unusual for a published RCT. They included in their appendices the inter-rater reliability. As you recall, there were 12 trained dentists, and so they included the inter-rater reliability here, which fared quite well. Now, was appropriate statistical analysis used? Again, this is not ITT. Now, this is referring to the actual analytical method that was used. It also refers to power and sample size calculations. And I won't read these verbatim, but if you go to the paper, you'll see that they planned very carefully their sample size to provide sufficient power, 90% power, in fact, to detect differences between the treatment and the control group based on the previous literature and what they expect to be the effect size in this case. And then they used binary logistic regression, which is an adequate approach for a categorical variable, which is what they had for their outcome, and a negative binomial method. Now, all of these different statistical tests require, you have to meet statistical assumptions. And you would also want to look for that in the description. But again, because of word limitations, sometimes it's not possible to go into so much detail. But from what we see here, it seems like the analysis was well conducted. All right, so I think this is the last question. So was the trial design appropriate and any deviations from the standard RCT design? You did see in a screenshot that I had previously that they did not change any of the measurements or outcomes throughout the duration of their study. It was a parallel type design. It's appropriate for the question that they're seeking to answer. This is all good. So for the overall appraisal, if you actually go through the checklist, most elements or components of that checklist were met. And so you would include this. Now, typically with critical appraisals, you have 2 or more individuals or researchers completing these critical appraisals, and any discrepancies can be resolved by discussion. Okay, so some strengths and limitations of an RCT. High internal validity because of all of the biases that the RCT helps to minimize, including the randomization, which infers that the results are less likely to be due to chance or confounding, and this is the only study design that can test for causality. There are some limitations, so threats to external validity, unless you're employing a pragmatic trial that we discussed, or you have some pragmatic elements incorporated in your trial that would help to make the results more generalizable to practice and to the general population, then this might suffer a little bit. They are expensive. So I currently work on several RCTs, and the numbers I see, I mean, yeah, my bank account would cry. So they can get very expensive very fast. It's also difficult to study rare events in RCTs, and actually I'll merge this with ethical limitations. Sometimes, currently I'm working with pregnant women, and there's a lot of considerations that you would need to take for different populations. As we mentioned, it's not always possible to mask participants or personnel. And then typically women, elderly, and minority ethnic groups are less of a focus in RCTs compared to other groups. So there needs to be more inclusion and diversity in that regard. So I know I am tight on time. These were some quick tips and tricks from my experience in conducting RCTs. So I'll just go over these very quickly. Before launching an RCT, I think it would make your life so much easier if you have a standard operating procedure and manual of procedures. So the standard operating procedures, or SOPs, refer to the exact procedure that you're going to carry for a specific measurement. So whether that is, for example, a VO2 max or a metabolic chamber test, any measurement that you take. Manual of procedures refers more to the details and logistics about the study. So I recently wrote an MOP, and some some things as specific as how to set a Zoom meeting. Essentially, you want your study to be as easily replicated as possible if someone were to come across your study documents. You need to also consider time management when it comes to coordinating amongst different cores, depending on which services you are seeking. So we use mass spectrometry cores, clinical chemistry cores, imaging cores for different measurements. So all of these need to come together to ensure cohesiveness. And then we also have visit checklists. So we have detailed checklists about what we're going to do with the participants when they come into the visit from beginning to end. So all of the steps that need to be taken within that time frame of the visit. Now, during the RCT, of course, you want to have complete interim data checks. You also need to consider obtaining medical records from your participants to ensure further eligibility in the trial. And then we typically keep track of, we have charts for every participant or patient. We document adverse events, CMEDs. All of these are essential because they help to provide an audit trail of how the trial was conducted and what are some of the elements that came out of that trial. And now I welcome all of your RCT questions.